So if you look at your handout, in the middle of it, it says abortion. And you have to remember that that's the formal term that we use. You never, ever, ever want to talk like that in front of patients because they'll never understand. But reality is any loss of pregnancy before 20 weeks, and you do want to write that, any loss of pregnancy before 20 weeks is termed an abortion. Again, you have got to never do that or talk about abortion in front of patients. They're going through what may be for them the most painful time of their life, and here you're calling it a term that is associated with a lot of negative connotation. So you just want to make sure you continue to use the language miscarriage with your patients, but the actual medical term is abortion if there is a loss of pregnancy before 20 weeks. Now, any bleeding before 20 weeks, any bleeding at all, is considered a threatened abortion. It's like, could be, maybe, happening. It could just be some other reason, and that's for us to figure out, not the patient. In other words, we teach all patients that if they have any spotting whatsoever in pregnancy, it's abnormal. Some people have told me that doctors told them, oh, it's normal. No, it's not normal to bleed in pregnancy. It can be common, but that does not equate to normal. So it's never normal. It can be some simple reasons, but it's not normal. Okay? Now, so you have some wonderful little terms there that you have in front of you, and we just want to take a couple of them and give you little tips. The first term is threatened. We already defined that. That's any bleeding before 20 weeks. The second term you see is inevitable. This one you want to remember, the cervix is open. So you are actually dilated. And once you start that, there's no turning back. So it's inevitable. Incomplete means you need a D&C, or a surgical evacuation. So a D&C. Complete means no D&C. Missed means there's no fetal heart rate at all. There's just no fetal heart rate. And the mother missed it because there was no other signs. So she didn't have any spotting, she didn't have any cramping, there was just no fetal heart rate. And then recurrent, 2 or more in a row. You want to remember this could be genetic. There could be a genetic reason for why that's happening. So we usually do chromosome studies. Now, of course, the latest statistics typically include 15%, although in anyone's OBGYN practice, including my own, I usually see 1 out of 4 will miscarry. And the reason why I say it's as high as 1 out of 4 is because pregnancy tests catch pregnancies before the period is missed now. So in your mind, you saw the test said positive, even though we call those chemical pregnancies, because if you did not have the ability to test before your period was missed, you would have never known that you were pregnant. You just would have had a normal period. 60% of all miscarriages are chromosomal in nature. It is God's way of selection. Just wasn't supposed to happen anyhow, kind of thing. Okay. All right, so that's that. Now, for the D and C, you just want to remember a couple things about that. Obviously, the D stands for dilation. The C stands for curettage or scraping. This procedure takes me, 10, 15 minutes tops. It's very short. So if a patient needed that after miscarriage, it's a relatively safe procedure. There is some teaching that goes on that you have to teach. And that's no sex, no tampons, no douching for 2 weeks. No sex, no tampons, no douching for 2 weeks, which if you know anything about female healthcare, you know that you should never douche anyway. It's the most incredibly outrageous exercise you can partake in. Okay, it's never been something that we thought was a good idea, and now we have evidence to prove it's actually very harmful. Okay, so no tampons, douching, or sex for 2 weeks. And there's always a risk of infection anytime I do surgery. So, you know, you're kind of watching and monitoring for that. There should not be a lot of bleeding. Bleeding should pretty much disappear after the first week. And the only other thing I would say to you about abortions is that you would have to know the maternal blood type, because if they are negative, they're going to need a RhoGAM. So if they're Rh negative, they're going to need a RhoGAM. Okay? On the left-hand side is ectopic pregnancy. And this is a pregnancy anywhere outside of the uterus. Anywhere outside of the uterus. It could be in the cervix, it could be in the fallopian tube, it could be between the uterus and the fallopian tube, but it could be anywhere outside the uterus, so that's all you care about. Typically it's in the tubes. You already know it's life-threatening, and it can kill you. It is the second highest reason for death to the mother. Hypertension is the first. So with this ectopic, what I tell nurses is any missed LNP, any missed period, any missed LNP with tachycardia is an ectopic until proven otherwise. Any missed LNP with tachycardia showing up in the ER is an ectopic until proven otherwise. That's why every single patient in the ER, if you're female, you got a little X chromosome going on, you're going to get a pregnancy test. Every single one of them. We don't even care how old you are, you know, we just do it. Okay? So your childbearing age, right? And you come in, you have not given me a period in the last 30 days, and you have tachycardia. Tachycardia is showing hemorrhage. Now, what are the signs of an ectopic? Well, maybe none. I've had that a million times in my practice. Maybe nothing at all. I just happen to find it on the ultrasound. It's very shocking when that happens. But typically, if you're going to have some symptoms, it's going to be unilateral or one-sided, unilateral, pain, and it's either in the lower left quadrant, LLQ, or the right lower quadrant, RLQ. So this is called the cul-de-sac, C-U-L-D-E-S-A-C, cul-de-sac. These little areas of the body are called the cul-de-sac. And I also have, remember it's where your ovaries are, so sometimes it's called adnexal area, cul-de-sac, or adnexal area of the human body is in pain. I may feel a mass in the cul-de-sac or adnexal area, which would be baby. I may feel a mass. That would be the baby. The patient may have spotting. Now, the problem, of course, is shock, hemorrhage and shock. This patient could bleed out. If they're hemorrhaging significantly, the abdomen will be board-like. We call it board-like, rigid abdomen if they're hemorrhaging. Now, that's going to be true for almost everything that we talk about with bleeding. A board-like, rigid abdomen is always some kind of internal bleeding, whether it's preeclampsia or abruption or a GI bleed or whatever. Pancreatitis, it could just be anything. Board-like rigid abdomen. Perforations, could be anything. Every time you see those words, board-like rigid, think somebody's bleeding inside. Okay? So we could have that. We could have a blue belly button, and that would be another sign of hemorrhage, and I want you to write this down. This would be called a Cullen sign. A positive Cullen sign is seen, then you know you're hemorrhaging, and this is a blue belly button. And you can see this with any number of bleeding situations abdominally. So it's a bluish belly button showing that we have somebody bleeding. The risk factors for an ectopic are probably more important than the ectopic itself. The typical risk factors for an ectopic are STDs, not all STDs, but gonorrhea, which I'm giving you the legal abbreviation, chlamydia. These can lead to pelvic inflammatory disease. Those are the reasons behind an ectopic. Number one reason. In other words, when you have chlamydia or gonorrhea, it started at the cervix and it moved up. So you have to know your anatomy to get this right. It starts at the cervix, it moves up into the uterus, and then it goes out into the sides, which are the tubes. Gonorrhea and chlamydia is an infection, obviously inflammation, and it's going to scar the tubes. So if you picture the anatomy of the female, and you think about what we just said, the infection started at the cervix, it moved up, and it moved out. And then it scarred the actual tubes itself. And so what you have to remember is, how is life conceived? Life is conceived with the little sperms going up here, swimming around. Ovaries have our eggs. The egg is released, and the sperm and the egg together meet right here. So the outer 1/3 of the tube is where conception occurs. Now, if a baby is conceived right here, maybe we move down a little bit, but not much, because all of this is scarred. So it can't get past that narrow tube. It can't find its real estate. It can't go and move where it needs to be. It's stuck in the tube because of the scarring. Another reason why an ectopic could happen, because we gave you gonorrhea, chlamydia, we call that PID, pelvic inflammatory disease, all of this infected. Number one reason for an ectopic. Another reason is maybe you have an IUD in place and the baby can't get in there because the IUD is in there. Or, this is very distressful to the mother, maybe her tubes were tied, bilateral tubal ligation. If her tubes were tied, then it's the weirdest thing in the world, because women are comical. They say things like, I want you to tie them, burn them, sit them out the window, throw them out. I don't want these ever. I don't want another kid ever alone for this. Okay, fine. We'll tie them, we'll burn them, we'll do all this stuff. So we're not lying to them. We burn, we tie, we already cut. And how do I know that we cut? Well, I take the portion that we cut out and I send it to the lab. The lab confirms fallopian tube for me. So I can prove that I cut your tube out. The problem is we're not in charge. And every time we think we're in charge, we screw this up. So since we're not in charge, this edge and this edge is considered free-flowing and just kind of doing its thing inside the human body. It's just free-floating. It's just doing whatever. Sometimes they connect. This free-floating edge connect and re-anastomose. grow into each other. Sperm, if you think of how does this kind of happen logistically, I want you to consider the tip of this pen is 6 million sperm. The tip of this pen. So sperm fit with no problem in this little area. The egg, it's a bigger. So the egg is not going to move through this area that's been cut, burned, and singed and everything else. But the sperm jump all the way through with no problem. And then the baby can't go past that cut, burn, singe area that you promised, that you begged us to cut and throw out. So, again, you have your risk factors for why this patient might have an ectopic. It's either going to be the number one reason, which is gonorrhea, chlamydia, and PID. Gonorrhea, chlamydia lead to pelvic inflammatory disease, or the fact that you may have an IUD in place already, which is so rare. I mean, because these two, the IUD and the tubal ligation, have the exact same failure rate, which is almost none. The failure rate is so slim. They're very good methods of birth control if that's what you want. Okay, so anyway, that's the deal, all right? Now, we have a patient who has a baby in the tubes. Can I do a DNC? What did I tell you a DNC was? Dilation of what? The cervix, and curettage of what? The uterus. Is the baby in the uterus? So don't screw that up. You cannot do a DNC on this patient and get the baby. No. You have to do what we call a tuboplasty, laparoscopic tuboplasty. Just keep in mind laparoscopic surgery. So we have to go into the mother, laparotomy oftentimes, and we have to sometimes take the tube. If the baby's really in there good, they have to take the tube. Something else I want you to remember about ectopic is they're generally less than 10 weeks along. So everything is happening very low in the pelvis. This patient's usually less than 10 weeks along. Everything is very low in the pelvis. Laparoscopic tuboplasty. In other words, don't choose DNC for this. It won't make sense. Okay? Now, if you're really early, super early, then we can use medication. That medication that I would use is methotrexate. Early, usually less than 7 weeks. It's a medication to dissolve the pregnancy. Methotrexate. It's also like a chemotherapy drug. Either way you go, everyone, your patient must be told the pregnancy cannot go on or they will die. The pregnancy cannot continue or they will die. We have not gotten fancy enough where we can take the baby out the tube and put it in the uterus and all this kind of stuff we wish we could do. And so essentially the baby must die for mommy to live. And that is a concept that is very painful for most of us.